Great, and I think we've got all of our presenters here as well, so I'll turn it over to Chair Doniate whenever he's ready.
Good. Thank you so much. I'll go ahead and call the meeting to order. So welcome everyone to today's statewide substance use response working group. This is the subcommittee on prevention. Today's May 23rd, 2022. At this time, let's go ahead and proceed with roll call.
All right, Senator Doniate. Oops.
Here.
Debbie Nadler.
Here. I'm sorry about last time.
Eric Schoen. Jessica Johnson.
Here. Good afternoon, everyone.
And Senator Gansert.
Here, thank you.
Great, thanks, Senator Doniate, or Chair Doniate, excuse me, we have a quorum.
Thank you so much, Emma. Great. At this time, we will go ahead and proceed with public comment. And just again, for those of you that are on Zoom and joining us, public comment will be limited to 2 minutes per person. This period is, of course, devoted to comments by the general public and for any discussion on items that we might have for today's agenda. Of course, this is just a reminder that no action may be taken during this period of time. So let's go ahead and proceed with public comment. Is there anyone on the Zoom that would like to go ahead and do public comment at this time?
Chair, I don't see any hands raised, so I don't believe there is public comment at this time.
Great, thank you. And Emma, just to make sure, do we have the phone line available?
I don't see anybody who has joined by phone.
Okay.
It is available, but I believe everybody is joining via computer today.
Okay, sounds good. I'll go ahead and close public comment, and then we still have one at the end of the meeting, I believe, so we'll be able to continue forward if we need to. Because of time constraints, I want to go ahead and move out of order now that I've closed public comment to agenda item 4, which is a presentation on preventing and understanding risk factors. Today we have Dr. Timothy Grigsby, who is a researcher at the Department of Social and Behavioral Health at the School of Public Health at UNLV. So Dr. Grigsby, welcome to today's committee meeting. Please begin when you're ready, sir.
You're on mute, Dr. Grigsby. Let me see if.
Is that better?
Yes.
Okay, great. I think I double clicked it. Sorry about that. So thank you for letting me know about that. I tend to double click when I don't mean to on my laptops. So thank you for letting me join today. I'm a researcher at the University of Nevada, Las Vegas School of Public Health in the Department of Social and Behavioral Health. I got my PhD in preventive medicine from the University of Southern California in 2016 and my undergraduate degree in psychology and social behavior at the University of California, Irvine. Where I began to express some interest in substance use and misuse and dovetailed in, I guess we'd say, from more of a treatment angle to a prevention angle following my bachelor's degree and wound up in public health. But that's another story for another day when we have more time. To give you a little background on my research and my interests here, my interest initially started with the conceptualization and measurement of substance misuse. And the idea of my initial line of research, which I still engage in at present, was trying to find the best way or the best metrics we can use to identify and screen and develop early intervention for folks who are experiencing the early signs and symptoms of substance use disorder. And from there, my research has dovetailed into a few directions. I've done a lot of my early work with the Hispanic and Latino community. And we found in some of our research that there were a lot of community-based risk factors that were present for this group that were unique to this group as well, that dealt with issues around immigration, coming from angles of acculturation versus assimilation, the idea of being not so much pressure, but this need to try and fill in a social role, if you will, that has an American face to it. issues of discrimination, not only based on things like one's skin color or country of origin, but even language or language preferences, or even in some cases with students I've worked with, just having parents who speak Spanish and they have to translate for them, or bringing to school, instead of peanut butter and jelly sandwich, bringing a chorizo huevo burrito, right? So these ideas, like these very subtle differences that, start to produce stress internally that is expressed externally through not only substance use, but also instances of bullying and bullying victimization and the like. So some of that work also trickled into the family arena as well, as I became more interested in what's happening at home and how it conflicts with what happens in our communities. I've done a lot more recent research around adverse childhood experiences, and this is, for those who aren't familiar with the term, from Folletti et al.'s initial Kaiser study in the late 90s, is really just a way for us to measure or try and understand the burden of family-based trauma. So this is not just what you might think of as like abuse, right? Physical abuse or emotional abuse or even sexual abuse, but also indicators of family dysfunction, right? So witnessing parental intimate partner violence, witnessing a family member become incarcerated, and so on and so forth, right? So trying to figure out which of these types of traumatic events tend to have the greatest weight in predicting substance use and violence and other related adverse health outcomes has been another interest of mine of late. So I've done a lot of work around that area. And what I wanted to talk about a little bit today, and I believe Sarah Marshall, I sent her a copy of a presentation I gave through cassette at the University of Nevada, Reno, is trying to move away from this idea of health disparities toward more of a health equity focused approach to prevention. What that really means is we need to really sort of change our thinking, sort of like in public health when we used to have this disease prevention framework where our goal was really, let's make sure people don't get sick, right? Let's get rid of disease. And if we get rid of disease, we've done our job. As we've moved here in the United States, right, away from really a burden of infectious disease and more to a burden of chronic disease, we've had to re-gauge our thinking, right? We had to take and kind of say, well, it's not just enough to say, let's treat obesity, right? Let's treat diabetes. It's really about promoting health. How can we make people the healthiest they could be? What can we do to allow them to flourish and have not only an improved quantity of life by extending those years or disability-free years of life, but how do we improve their quality of life? And really that same sort of paradigm shift needs to happen for us right now within that health promotion framework, where we need to move away from this idea of saying, well, look, these groups fare worse than these groups, to trying to figure out, well, how can we actually truly balance the scales? How can we meet people where they are and provide the resources they need, be them a community or a population or a subpopulation or even a sub-community, if you will. What can we do to bring the most effective prevention strategies to those people based on where they are and what resources they have? And that takes quite a bit of work, right? But we really do need to start getting into the weeds, because unfortunately what we see a lot of times in substance use, and I'm sure you folks can back me up on this too, right? On the treatment end, we get people into treatment, the treatment's going really well, and then we throw them back into communities, and those communities have not been fixed, right? So we are trying to give them skills that they don't really have a chance to practice because they're in an inpatient treatment facility or they've been taken away from those community risk factors, and we throw them back in with no real resources on the ground there to help them with their recovery efforts, whatever those efforts might look like. On the prevention end, we need to do something similar. We need to take a multi-level approach, right? If we want people to change, then we need to make sure they're in families that embrace that change, in schools and workplaces that embrace that change, that's driven by policy, that removes the stigma from wanting to get help when they need help, and tackles that problem from as many angles as possible. So I'll stop talking there before I get further down the rabbit hole, but I'm happy to take any questions you might have specifically about some of those points I brought up, or any discussion of issues you brought up before that I could probably or hopefully shed some light on.
Sure, and thank you so much, Dr. Grigsby, of course, for joining us here today. Your expertise is very valued, and I think with some of the questions from our committee members, I think we'll be able to have a better understanding. So I'll start us off first. Given that we are in the process of determining policy proposals that could be formed into recommendations for particularly in terms of prevention. I guess my question for you is, given your expertise, given your research, what's the biggest funding priority right now or policy priority that we have to probably look at right now to solve this crisis? And then what do we need to do in the future? What are proposals that we should be looking at to support prevention from an upstream approach?
Yeah, those are two really fantastic questions, and thank you for those. I think the first, to answer your first question about the most pressing need right now, is I think we need to take a two-pronged approach. One, we need to support evaluation of ongoing services and efforts in our communities to make sure what we're doing at present is working, and that we can identify where the gaps are so that we can fill those in with other programs or other efforts that are needed. And the sort of second part to that question is, I think we need to do some more work around polysubstance use. The data is becoming really clear that it is not a single drug issue. And we've seen this, I think, very clearly demonstrated with the opioid epidemic, right? So as folks, for example, as we started to put tighter restrictions around prescription opioids, for example, we saw this sudden uptick in heroin resurgence. And the idea there really is, right, that addiction from that disease model perspective, if you will, is not limited to a single substance. So in writing policies or making recommendations, we want them to be as broad as possible to capture as many drugs, psychoactive drugs, right, as possible that could lead to overdose, either when used solitarily or used in combination with one another. Fentanyl is another great example. Trying to help folks gain access to fentanyl test strips, be educated on how to use them, so that if they are taking that drug willingly or unwillingly, when they purchase street drugs from dealers and the like, is something that's necessary. So broadening it out to polysubstance use and trying to write policies that are much more encompassing will serve us much better. And that sort of dovetails into your second question. And moving upstream, we need to be more mindful or thoughtful, drawing back on Thomas Frieden's health impact pyramid, right? His idea there, though he was initially looking at chronic disease, was that a lot of what we do in public health right now is much more individual level, right? So we try and do education and reach people one-on-one. We do not do a lot of work at the higher levels where we can make the greatest impact. So if we really want to see true social change, we have to attack not only, right, the problem at the person level, we need to attack the structural levels. So we need to make sure that we are giving schools opportunity to offer prevention programming. And that's, of course, a daunting challenge in and of itself, right? Our teachers and our nurses and our principals, they're overwhelmed as it is. So how do we properly support them or give them access to resources that could work and could be implemented with fidelity is something we need to think about moving forward. So I saw another hand, so I won't go further down that rabbit hole unless you wanted to ask a follow-up question there, Senator George.
Sure. We can come back to it, but given the limited time, I'll let the other committee members go for it. So Ms. Nadler, please proceed.
Hi, thank you, Dr. Grisby. We're glad to have you here to give your knowledge. I do have a question for you, and excuse me for sounding ignorant on this question, but when you were talking about communities, putting the kids back into the communities and seeing where they'll go and how you worked with different types of population in your field, what communities are you talking? Are you talking about all communities? Are you talking about the diverse communities, or did you work with, I guess my question is stemming from the fact that when I look at the models and I look at the numbers of the kids that we're losing in our state of Nevada, it's 70% Caucasians. And I really don't mean to sound ignorant, and excuse me, but I don't understand why we're focusing just on trying to just do racial diversity when it's affecting all our kids. My son was, a Caucasian, white, he was Caucasian and in school, straight A student and using. Most of my friends, their kids were the same. But I can tell you one thing they did all have in common, and I'm glad you talked about in schools and early childhood. Most of our kids were given Adderall and Ritalin in 3rd grade. It seems to be a common denomination between, and I work with 100,000 grieving moms across the country. So I don't know if you found out something like that. And divorced. Most of us are divorced too. So
you bring up a lot of great points, and thank you for your advocacy there. As a parent, I you know, it's heartbreaking to work, and I work with a lot of parents who've lost their children to addiction. And you're right, it does not discriminate. It's just like any other disease, right? If you happen to have that genetic predisposition and the access, and one bad incident where you took a drug that you didn't mean to, or you consumed more than you could handle, that's all it takes. And there's nobody around, and especially too, and that's where stigma is so important, right? Is if you're stigmatized and you don't have a place to safely consume, so you decide to go do it on your own, let's say heroin, right? And heroin has a really high tolerance, so people escalate their use really rapidly, and it's really easy to overdose as a result of that. And so you're by yourself, you take too much, and that's all it takes. And when I mentioned earlier about that idea of putting people back in communities, what that really means, right, is sort of you've taken, the problem is not individual, right? Most people, I could say probably safely, 99.9% of the people I work with do not manufacture their own substances. They get them from somewhere. They use them with others. They are encouraged by others to use. It's part of their identity for a lot of folks, right? And so when we take people and we remove them from that setting, right, we say, okay, let's take you out of there. We'll put you in treatment. We give them these skills. We teach them to cope a little better. They feel like they're on the up and up. Then when the treatment's done, the money runs out, the program's over, the bed's gone, we just plop them right back in. And it's, when we think about that from a prevention standpoint, or if we think about relapse prevention, it's like, what are we really doing? What are we really going to succeed at if we haven't corrected the problem around the person, right? We have given them some skills, but those skills are only going to go so far, which is why Nancy Reagan's Just Say No program didn't work, right? It's great to just say no, but that only goes so far as a skill. If you live in a drug-ridden, gang-ridden community, and you're the one kid who's going to stand up and say no, you're going to stick out like a sore thumb, right? So without fixing those at the structural level, at the community level, at the systems level, we're not going to successfully help people change. And that's where the equity part is so important, right? So like even what you mentioned, like there's, we talk a lot about disparities, right? There happens to be this idea in prevention science we call the equity effectiveness trade-off, which essentially just means, right, as you could probably guess, right, if you have more privilege, then treatment programs are going to be more effective. Prevention is going to be more effective, because if we say, hey, just say no, and you're somebody who comes from a wealthier family, and you say, hey, the kids at school are trying to make me take drugs, they say, oh, well, no problem. We'll move you to another school. You'll get off the bus. We'll drive you to and from school. But for a lot of families, that's not an option, especially single parent families, being a single parent and trying to coordinate even just drop off and pick up from school 5 days a week is a challenge, and I have, my wife's a nurse, and so I get caught with that aspect of it a lot, and that's a heavy burden. And trying to think about parents who do that all by themselves 24/7, 365 for 18 years, right, with their kids, to them no longer their responsibility is a challenge. So what we have to really think about is, well, how can we help? The best way we can serve people is we have to serve the communities in which they live, right? If we can help to remedy some of those gaps, provide those resources, help reshape the communities, then when people do need that treatment, we can put them back somewhere where they actually have a chance to exercise those skills. They have a support network in their community to draw on, and that'll be a way for them to better succeed. So I hope that gets to an answer to your question to some extent in the time that we have today.
It does, and I agree with that. My son was in 9 rehabs across the country, and they just let him go. It's like, it's putting just being in rehab and not having the mental health or a so-called social worker follow them. I don't understand. it was like putting a Band-Aid on a bullet wound.
Right.
So
And then throwing
I
them back
agree.
on the
Yeah.
field, right? And then saying, go
Yep.
back and try not to get hit anymore. And
Correct.
that's it.
Correct. Yep.
Yeah. Well, I'm sorry for your loss, and thank you for sharing that. It
Thank
is
you.
a really
No,
important
thank you.
part of this puzzle.
It is.
Great.
Thank
Thank you so much, Dr. Grigsby, for answering that question. Any other committee members that may have questions at this time? Ms. Johnson, please proceed.
Thank you, Chair Dunyate, and hi, Dr. Grigsby.
Hello.
So great to see you
Likewise.
on today. I was really glad to see your name on the agenda. I wanted to just reflect a moment on your comment about moving from more sort of individually tailored programs to thinking about these community or systems level solutions, and wanted to sort of maybe hold some space for your recommendations about either considerations from a policy level here or resources for this committee to continue to think about, so that we can look to have, you know, the biggest impact for the most good here.
Yeah, that's a great question. Thank you for that, Jessica. I do appreciate it, and it is something I've given a lot of thought to. One of the things I will mention as a caveat here is I've only been in the Las Vegas area for 2 years, so take that with a grain of salt. Right, so I moved here in the midst of the pandemic, which meant I was like inside for the first year and a half that I lived here. But you know, one of the things I will commend Nevada for is Nevada tends to be, relative to other areas where I've worked, much more proactive in a lot of ways, and much better at securing funds for programming and trying to coordinate those efforts to address pressing health issues, which I am very appreciative of. One of the things that drew me to UNLV in the first place. So again, if I'm speaking out of turn, feel free to correct me if I've missed something. But one of the things I think would be great is I've noticed so far in my time here is that, like I mentioned a minute ago, seems to be a lot of services, a lot of resources that are available. But one of the things that seems to be lacking, at least from my perspective, is a coordinated front for those efforts. So how to better connect these various agencies that are doing great work from prevention to treatment. What can we do to build a true, I don't know if we want to call it a coalition or a network that could support individuals who are experiencing substance use problems? Is something that could be very important. And Nevada and Clark County in particular is a pretty unique setting as well, given that, right, we have, I think I saw something like 85% of our population resides in Clark County or Southern Nevada. And we are also a highly visited tourist destination. Much of that tourism is focused around substance use, right? So people come here to drink and to party and to use those other drugs. And some of the conversations I've had with folks on the treatment end, we do see a lot of tourists here end up in our treatment facilities on I can't remember the hold, 5150 holds, I think it is, right, who have become potentially harmful to themselves or others due to a drug-induced episode. So trying to build some services that will serve not only our local community, but our tourists as well is necessary and needed. I will say there's been some good success stories elsewhere in the country with safe consumption sites, though those are challenging to set up and maintain and require a lot of funding. They tend to be relatively impactful in reducing overdose deaths. And those are the same kind of places where wraparound services can be offered, right? So people are not only dealing with substance use, but are dealing with violence or sexually transmitted infections or infections from drug use, from injection drug use, whatever the case may be. Having a place where folks can safely consume, reduce the risk of opioid overdose or overdose from other drugs is really important. Those two things I think come to the front of my mind of being really meaningful and impactful. The other systems issue I think we need to address is in our schools, right? Our school district has seen a pretty strong uptick in not only substance use, but mental health issues since the pandemic began. And now as they're returning to campus, it has not attenuated as quickly as we would like to see. I'm sure you all read the news stories of the issues we've seen at campuses around Clark County. So again, how can we best support those schools and bring those resources to them you know, and again, I'll try to sum this up as quickly as I can. I apologize. But you know, one of the issues I've faced in my own work elsewhere in the country is a lot of times when we get funding from, you know, either nationally or from, you know, local or state agencies, a lot of times the onus is still placed on the school to provide these services. And so we're asking teachers who are already held to 1 million standards to now tack on one more. And that ends up damaging our ability to do meaningful work in those settings because it is not at the forefront of their needs, right? Their careers, and we have to put ourselves in their shoes, right? Their careers are based on educating those children and making sure those children perform well academically and on state tests. So that's where the priorities go. So what can we do to bring resources to the school and reduce the burden on the staff? And at the same time is a challenge, but it's something that can be done. The real question is how much, right? How much money and how much manpower can we throw at the school district? But you know, the work, you know, existing prevention work to date shows that when, you know, the earlier we work on intervening and bringing that prevention focused skill set to people, the better they fare long term, right? Before, if we can, you know, make the healthy choice the habit, then that's even better, right? So what can we do in that respect is something we need to focus a lot more on, and how to do that meaningfully. Hopefully the internet will provide us some good resources, right? So we can deliver these things electronically or develop something that's more interactive than somebody boring and old like me coming in and tell a bunch of kids don't do drugs, right? Because that's not going to get the message as clearly across as something more engaging and interactive and immersive, where they even have a chance to practice those skill sets. So I hope that gets a little bit to your question, Jessica, and I'm happy to share some of those success stories in the peer-reviewed literature with you, and you can disseminate it to the group as well.
Great, thank you so much for taking my question.
Of course.
I'm going to see. Thank you so much, Jessica. And I don't. Perhaps I'll again, if there's any committee members that have any questions, feel free to let me know. Dr. Grigsby, is there a state that you think is at the forefront of this issue that we can look at?
Oh, that's a great question.
Infrastructure or services.
That's a really good question. Trying to think if there's a good model state. I mean, the real problem is the states that I've seen that do well do not have a similar makeup and structure as Nevada. So it's hard to compare them to say, we could take what's working there and make it work here and make it work as well here as it's worked there. I will say to an extent, right? California tends to do a pretty good job on the prevention front. They bring in a lot of prevention focused efforts, and you know, a really great example from one of those lines of research I do is in those childhood trauma and ACEs. Is they started the ACEs Aware program through Medi-Cal to screen for ACEs at primary care visits. It's a really fantastic example of how we can take a known risk factor and determine it for a pretty wide array of behavioral and physical and mental health problems and integrate it into part of the primary care experience. So that might be one program to look up in California. I think that's really meaningful. In terms of a state, boy, I don't know if I have a state that I would say is at the forefront that on all fronts. I think we're all struggling in our own respects to handle this, you know, this addiction crisis we've been seeing now for the last decade. But I'll give that some more thought, Senator Daughtry, and I'll come back to you at some point, maybe with a better answer than I could probably give off the cuff.
Yeah, I would say if, from some of the things that you've mentioned today, if you can forward us policy considerations that have been taken in other states that you feel are good models, whether it's to improve health literacy or any of the prevention sub-factors that you mentioned, I think that'd be very helpful for us to review. And it sounds like you probably have to head on soon. So final question, if you were giving the drawing board in the same way that we are for some of these subcommittee members, and financing might not be a big issue as it is in general grants or processes, what would you prioritize? What would that project look like, or policy proposal?
Yeah, that's a great question. So yes, in a short response, I think I would fund my efforts to programming that's going to reach young people, that's going to address not just drug use, but is going to address the underlying skill set that they need to be successful, because the pathway to drug use, to escalating drug use, to substance use disorder is varied. No two people share the same experience, but they tend to have similar experiences. So teaching them how to, for example, cope with racism and discrimination, how to manage stress, how to ask for help, helping them to partner with positive adult role models. That'd be the kind of program I think is needed, that we could integrate not only into schools, but into community settings for our young people in particular, so that by the time they become adults, they have that toolkit they need to thrive and be resilient in the face of challenges that they're going to undertake as young adults, when most substance use behavior begins and also escalates into substance use disorder.
Great. Thank you so much, Dr. Grigsby. I know you have a meeting that you have to get to, so we'll go ahead and close this agenda item for now. I encourage any of the committee members, if you have any follow-up questions or conversations that you'd like, we'll go ahead and have Emma and the committee staff forward Dr. Grigsby's contact information, if that's fine.
Yes.
And then hopefully when we're reviewing policy recommendations, we'll give you the chance to, as we have for everyone else and other speakers, to be a part of the process for when we review and make our final recommendation. So thank you again for joining us today.
Of course. And thank you so much for having me. And I look forward to having the chance to discuss some of these issues further with you all.
Great. Thank you so much.
Thank you, everyone. Have a good afternoon.
Let's go ahead and move back in order to, now that we have concluded that presentation, let's move to agenda item 3, which is to review and approve the minutes from April 25th, the prevention subcommittee meeting. At this time, members, do you have any questions, or are there any changes or corrections that should be made to the agenda? And seeing none, at this time, I'll go ahead and ask for a motion to approve the minutes from last meeting. So, do I have a motion? We have a motion from Ms. Nadler. Do we have a second?
I'll second. This is Jessica Johnson for the.
We have a second from Ms. Johnson. Great. All those in favor, either you can unmute yourself or raise your hand. That way I can see. Sounds good. Okay. Looks like the unanimous vote. So any opposed? Any abstentions? No. Okay. The motion passes. Great. Let's go ahead and move on to our next agenda item, which is a presentation from the Nevada Prevention Coalition update. Today we have Ms. Linda Lang, who is part of the Nevada Statewide Coalition Partnership. So Ms. Lang, please proceed.
Thank you very much, Chair. I'm going to go ahead, and I think either Jamie Ross or Sarah or Emma are going to bring up the PowerPoint presentation. But while they're doing that, I would like to go ahead and thank one of your subcommittee members, Eric Schoen, for bringing forth. That's wonderful. That's wonderful. Can it be made a little larger?
Yep. Give me just 1 second.
Okay. I'd like to bring forward Eric's name and thank him on behalf of the coalitions in the state of Nevada for allowing us to provide recommendations to him as a member and him moving them forward. It's been a great exercise, and looking and collaborating statewide as to if we had, the world is our oyster, what could we do in the prevention field? So what we are going to do today is we are going to walk you through the recommendations that we submitted to Eric, which he submitted to you, and that is that tracker sheet. The reason that I have Jamie Ross presenting with me today is that I am the director of the Nevada Statewide Coalition Partnership through the end of July. I will be leaving and retiring, and Jamie Ross will be taking over in August. And so we thought it would be good for both of us to co-present today, as any future involvement will be with Jamie. So go ahead, Jamie. For many of you,
Sorry. Oh, there we go.
For many of you, this is not going to be something that is foreign, which is our prevention coalition structure in the state of Nevada, but I don't want to ever make an assumption, especially for some of our legislators that are on this subcommittee. But the Nevada Statewide Coalition Partnership really is a collaboration of all the community coalitions with a primary focus on substance misuse in the state. And this shows how long the coalition structure has actually been around in the state of Nevada. The earliest coalition that was developed was, I think, in 1989. That was Partnership Carson City. And many of these coalitions were informal back in the day. But once the statewide partnership was established in 2001, it moved the coalition model into a formalized coalition process in the state. So as you can see, there are coalitions in the state that exist currently that serve all 17 counties in the state of Nevada. The information that Jamie and I are presenting today comes from all of the executive directors and their staff, not just from the two of us. Next. Jamie and I are going to present two portions of the very, very large document that you guys received, all the information on the tracker. We're going to focus on the recommendation and the justification sections because those really have the meat to our recommendations. The research links are in another column, so all the research that those of you that like to do that can go ahead and look at those links. All of the AB 374 requirements were met in the various columns. That's important. The funding will be addressed a little bit throughout this, but if there's any really deep dive, that can happen during the answer and question and answers at the end. So we are going to give very brief overviews of 8 different recommendations because each one of these actually could be a standalone presentation on its own. So we're going to be brief and as much as we can, and then allow for questions and answers at the end. So I'm going to start with the very first one, which I think is one of the most important. They're all important, but this one is very, very important. This one was addressed in your last meeting that you had where Dr. Woodard presented her introduction to the prevention work in the state of Nevada. And she talked at length about this exact topic, which is we need to provide support for secondary prevention, which can also be termed early intervention. And these slides are for you to get a copy of later, and you can look at these in details. But basically, in a nutshell, we have money that comes into the state right now from the state and from the federal government that supports primary prevention. And primary prevention stops once a young person or an adult has began to experiment with a substance, or they have entered into that risky behavior. And the grant sources are very, very strict. The services stop right there, but that is not how the world works. We right now at this point in time have kids that are in crisis within our state, and we are in need of allowing the prevention coalitions and all prevention program in the state to move over to secondary prevention. And this is where if a warning sign is seen, the brief screenings can occur and they can get help before it goes into a treatment modality. This could be motivational interviewing in schools, drug testing, signs of suicide. There's tons of different types of early intervention tools that could be utilized not just in the schools, but in primary care, through community coalitions, et cetera. There is a Project Aware, which is a school-based mental health program that has phenomenal success in our state, but it is one county and one school district at a time that gets funded. It has been very, very successful in helping kids and establishing a structure for mental health in schools. And one of our recommendations is that we offer evidence-based programming, such as social and emotional learning in the schools, possibly giving the kids credit for taking the intervention program and giving it to them before they enter the juvenile justice system. Next slide. The justification, I went over this already. Current funding supports primary, but does not support the secondary or the intervention. The resources are needed now before they get treatment. And what's most important, I think, for you to know is that our state substance misuse dollars have decreased by almost half since 2007. And none of the current money that the state of Nevada provides for substance misuse can go to this area, the area between prevention and treatment. Next slide.
So sorry. I'm trying to both run the slides and unmute myself. So thank you. Jamie Ross for the record. One of the things that we have heard in nearly every public meeting we've been to is workforce development. We all know this is a huge issue. Youth workforce development and focusing on our youth really focuses on the grow your own model, which has been really successful in a lot of other states. Focusing on scholarships. And that is scholarships for the paraprofessionals, scholarships for the certifications that are growing. I'm thinking community health workers. I'm thinking peer recovery support specialists. There's currently the ability to actually get some of these certifications when you graduate high school, if you are lucky enough to be in a community that has a teacher who can teach that. So working with work-study opportunities and increased opportunities for licensed supervision. One of the things that the pandemic has really taught us is that it is absolutely possible to do so much more via Zoom than we ever thought possible. And to ensure that one of the issues, especially in our rural communities, is all of the professionals, the licensed clinical social workers, the all of the folks who need X number of hours of supervision. If you live in a county that doesn't have a supervisor, or that supervisor is already full, then that community that is already in desperate need of a new licensed clinician now has one more barrier. So making sure that we can continue to do remote supervision. And this is something that we want to make very clear of, is increasing the flexibility within our communities to address these needs. One thing that we've heard a lot of is and I live in Las Vegas, and I can tell you that the way a program is implemented in Henderson is going to be very different than the way a program is implemented in urban Las Vegas. It looks different. So increasing the flexibility and obviously keeping the parameters up to make sure that everyone stays safe, but being really aware of that. And so we talked a lot about the justification already. The career technology education, that's the certification model where you can actually get certified in high schools, supporting that for our rural communities through virtual classrooms, et cetera, and funding our certifications. All of these things are absolutely possible to do tomorrow. All they need is money. And I don't know if you guys are aware, but we have a lot of that coming into Nevada. Our second project is ACEs, or our third project is ACEs mitigation. You heard Dr. Grigsby speak highly of addressing ACEs. ACEs is adverse childhood experiences. ACEs mitigation has been recognized by the CDC for many years now as a fundamental risk factor for substance misuse. And it addresses, if we can mitigate our ACEs risks, we can not just reduce substance misuse, but we can reduce all sorts of societal issues. Some of the ideas or some of the projects could include social emotional learning, dating violence prevention, parenting programs. And as far as the justification goes, this is something that we've heard through multiple divisions within DHHS already. There is support of the ACEs model. Interestingly, UNR just created UNR is the one who does the Youth Risk Behavior Survey, which we call the YRBS. And they just did their first ACEs model where they were actually able to pull out ACEs. And the same thing was done with the PRAMS survey, which is the Pregnancy Risk Assessment Monitoring Survey, I think. And unsurprisingly, new mothers who had a much higher ACE score were more likely to use all sorts of different drugs while they were pregnant, while they were breastfeeding, et cetera. And so continuing to fund these programs and increase funding for them. And Linda? You're on mute, Linda.
Thank you, Jamie. Many of you have heard about the Most and the Fast teams, and I will briefly go over what these are for those of you that aren't familiar. But a lot of people say that this might not be relevant in the prevention world, but it's more of an intervention, or it borderlines on the treatment. But we disagree because this program has been very, very, very successful in preventing people from re-engaging in substance misuse or in the jail system, such as, once again, Dr. Grigsby was talking about earlier today. But we need to support this and build on it. There are dollars coming in through other grants that do support this, but not to the capacity where it needs to be. A MOST team, for those of you that aren't familiar, in 2 words or less, basically, is law enforcement and a clinician on the streets and dealing with issues as they arise, trying to divert people from entering into the emergency rooms or entering into the jail system. They a lot of times term these people as being frequent flyers, and they take up, because they just keep going around and around to the various social service systems. They take up a lot of time and a lot of money, and a lot of mental health issues are related to the clients, and that can be diverted with a team of people that are out on the streets. Whereas the FAST program is a jail diversion program, primarily for substance misuse, also mental health, but usually substance misuse, that basically tries to keep them out of coming back into the jail system, provides a safety net for them. Next slide. They are designed to bridge the gaps between mental health and other supports, and it helps reduce the number of crisis calls and the needed resources for these clients. And one of the most important things that we put in the budget section for this is the training of officers in the mental health awareness, the crisis intervention teams, and the evidence-based program. That's what EBP stands for, Curriculum for Inmates. These are all critical pieces of this program. As I said, we put the Most and Fast as a priority in our communities around almost anything we do, because it has been really, really valuable. As a closing to this, it's important to note that in some communities, they can only have their MOST teams on the streets 2 days a week because of the lack of resources. Some are 3 days a week. So they're not able to be there when the clients actually need them. You know, crisis does not just happen on Monday, Wednesdays, and Fridays. So next slide. Jamie.
Thank you. And so this is another model that we've heard a lot about. Dr. Stephanie Woodard and others within DHHS are in support of collective impact training. And collective impact, it's a network of community members, organizations, and institutions who balance equity by learning together, aligning, and integrating their actions to achieve population level change. And so I say that to say, what we're hoping to do is to bring the collective impact training to our communities so that it's not something that lives in a binder in one person's office, but to actually bring it down to the community level, supporting our key stakeholders to create this collective impact approach, and establishing an operating standard for community engagement for our systems change. One of the things we heard Dr. Grigsby say is that systems level change is where we can have the most bang for our buck. If we're looking at prevention dollars, systems level change does that the cheapest overall, and really focusing cross-sector and cross-discipline for training, for collective understanding, and then making sure it's not something that just happens at one agency, but is from the state level all the way down to our coalition and our community levels. And the justification for collective impact is it's really an intentional way of working together, sharing information to solve complex issues. We know that these issues that we're dealing with are so much more nuanced and challenging than just, we can't just throw money at the problem, although we definitely want to address the funding needs, but really centering equity in this work. We know that a lot of the work that has been done historically has stigmatized some of our marginalized populations, and making sure that for sustainability, we utilize the community coalitions that were institutionalized in Senate Bill 69 in the
Jamie, I think you might want to try turning off your camera. We're having a little bit of audio issues.
You hear me now? Oh,
Yes.
Okay. Thank you. And so that is why we think that if we utilize the coalitions, will ensure that this training is sustainable in our communities. And another, this dovetails perfectly with what Dr. Grigsby said, was providing certified prevention specialists, or CPS, in Nevada schools before or after school programs and our youth serving organizations to provide appropriate prevention education and programming. CPSs are credentialed through the ICNRC, which is the International Credentialing and Reciprocity Consortium, and to demonstrate competency through education, supervision, and passing a rigorous exam. Really, the goal for this would actually be to have certified prevention specialists in as many schools as possible statewide. One of the things that we hear all of the time is that, we expect our teachers to be all things to all people, and they are not experts in this field. So providing them an actual expert in this within the community, that also within each school, they would be able to provide prevention programming, data collection, SBIRT, which is screening, brief intervention, referral to treatment, screenings, as Linda was saying, with the secondary prevention programming, as well as the full prevention framework, as well as utilizing the multi-tiered systems of support, which most of our school systems use currently, and addressing the appropriate target populations. As well as our 7th project is formal youth mentoring programs. We know that youth mentoring happens informally and semi-formally all over our state. One of the things that we've noticed is most of our communities outside of Washoe and Clark do not have a formalized mentoring program such as Big Brothers Big Sisters. And we know that this, as far as reducing ACEs, is one of the top models nationwide. And one of the things that we've seen is it supports our social emotional learning, and so many agencies are desperate to help, but this formalized process will ensure safety and best practices for both our mentors and our mentees.
And finally, we could not leave a recommendation list without talking about data. And this is a little bit different because we do have so much data collection going on in the state, and really quite a few dashboards, quite a bit of data that is floating out there all over in the state. What we do not have is improved local level data collection systems. And what we are recommending here is to actually contract with a company that can provide individual consultation to the entities across the state to help them improve these systems. And the second step would be then to hopefully create a comprehensive statewide data sharing system that includes all the data dashboards and the public data. But truthfully, the first one would even be quite the large step towards getting better data for our state. Next slide. The reasoning for this is the current data does not necessarily represent our individual communities. This has been something that I know that most people on this meeting have heard before, is that counties are lumped together, communities are lumped together, regions are lumped together. They can't be compared across the board because they are done differently through data, different data sources. And this is necessary for grant funding. All grants require valid data. And we are losing out on grant opportunities because of some of the local level data. At times we have to use national data, and that does not reflect what's happening in our state. Also at the local level, many agencies, counties, city, nonprofits, etc., they don't have the capacity to build and maintain a robust system. They just don't have the capacity. And if they have somebody that's in there, they might leave. This needs to be something that is embedded into communities throughout all of the sectors. It'll allow for a standardized data analysis system that'll aid in identifying risk factors and protective factors in a community. And it'll help us to be able to compete for federal funding by becoming a sustainable hub to help with informed strategies that we can implement. Once again, engaging an expert is crucial to this process. Having somebody that is designated within a certain agency to do this, it's not going to work. We've tried it in the past, to be honest with you. Many data systems have gone down the wayside when an entity goes away or a person goes away. So we really would like an expert to come in and work with all the local level communities at a grassroots level to create this system. Next slide. Jamie and I want to thank you for the opportunity to share today. And those are our contact information. Mine's through the 31st and Jamie's through the beginning of August and after. We'd open it up now to any questions on any of these recommendations from the group. Thank you, Chair.
Thank you so much, Ms. Lane, and of course to Jamie as well. And I'm grateful that we have you before your retirement, which I'm sure you're excited for to finally get the chance to relax. So I'm gonna allow my committee members a chance to ask any questions. I just have quick clarification, because we always talk about the funding that's out there that we could be approaching. You mentioned data as a big part of that factor of how we can apply to grants. So just to clarify, for a lot of the funding that we have in this space between primary, secondary, and tertiary prevention, most of the funding is usually guided, as you mentioned, towards primary prevention. So are there grant dollars that we can go after in secondary prevention? It's just that we haven't made the motions yet to get to that part. Is that what I'm getting from the presentation, or can you clarify a little bit on the challenges that you've had, of course, when applying for these grants?
I can. Thank you, Chair. It's really interesting because the same dilemma we're seeing within our state, we're seeing nationwide. This has been something when we go to our national conferences or have our conversations with SAMHSA, that's a Substance Abuse Mental Health Services Administration, where a lot of the funding comes from, and with CADCA, which is sort of the model the coalitions follow, Community Anti-Drug Coalitions of America. Sorry for the lengthy acronyms. We have heard that at the national level, this is an area that they are moving to also. But no, to answer your question, I've said there's no money. Example is one of our major sources in our state is the block grant. Substance abuse block grant only allows for prevention to be focused on primary prevention. They're very strict about that, the 20% that's carved out for prevention. And what that looks like is that if somebody is receiving a service or something, a program is happening in a school or in a community, but that child then moves towards experimenting the first time. That's why we have drug testing, to be honest with you, in the schools to try to intercede before it goes any further. Truthfully, the dollars are supposed to stop. You're not supposed to be able to provide the services any longer to those kids. And it doesn't make sense in trying to serve population of youth, but it has been a huge gap. I'm going to say for 15 to 20 years in our state. So I hope that answers your question.
Yeah, well, I guess, and then the follow-up to that would be, would it be safe to say that, considering that from the national conversations that you've had, that there is going to be a pivot eventually to opening this as potential grant opportunities, if the state chooses to invest in this sector of prevention, that could set us up to getting even more financial dollars in the future once these grant opportunities are open? Is that something that you could foresee in the future?
I could. Exactly what you said, I could see. And they are starting to dabble a little bit in it by the harm reduction, which isn't exactly what we're talking about. You know, the harm reduction is a little bit different, but they are starting to have the conversations about what they will support. And it's really interesting because it's all a matter of the semantics and how close it gets, to be honest with you, to treatment. And so there's the conversations happening. But yes, I think it would poise us to be very ready.
Great, thank you so much. Ms. Johnson, please proceed.
Yep. Thank you, Chair Danyate, and thank you, Linda and Jamie, for a really wonderful presentation. I had read through the suggestions from Eric, so it was great to have some context about some of those pieces. I have several questions, so maybe I'll ask a few and then default to the rest of the committee and come back if there's time. I wanted to hear from both of you if you wanted to elaborate on the drug testing piece. I was really surprised to see that included as part of a determining factor to move from primary prevention to like an indicated or secondary prevention. I had understood prior to today that was actually recommended against and in terms of a screening tool in primary prevention for a variety of reasons. And I apologize, I wasn't able to access the links to the Buffalo website that you provided. So perhaps there's more detail in there, but I wanted to give you a chance to share more about that. I have concern just based on previous efforts of people using drug testing as a primary prevention sort of avenue, and wanted to hear your thoughts on that.
I can address that. I'm going to give an example. You just brought up something, Jess, that's very important, is how does this fit into prevention? Because it is drug testing. I'm going to tell you a little bit about what's happening in our state right now. Many schools do have drug testing on campus, many of the schools. I don't know if they have it in Las Vegas, I'm going to be honest with you. Hopefully Jamie could maybe tell us that, but many of the rural communities do have drug testing, and it is used in relation to the NIAA. And that is the Nevada Interscholastic Activities Association. And the idea, and it does work, being that randomly, those that have signed off on a contract and those that are engaged in extracurricular activities, sports is primarily the one that's focused on, but it's all activities now. They changed the name actually from Athletic Activities Association. And doing the random drug testing can very early on stop a person from, as I said, entering into that next step of using substances on a long-term basis. And the process that's set up in the state right now through NIAA is they already have an education component, that the first time somebody is drug tested and found to test positive, there is an educational component for the parents and for the students. There's a 3-step process. I won't explain it all today, but there's a 3-step process. And the whole idea is for the student to stop and to get the help that they need or the education they need right away before that progresses any further. One of the most successful programs that was implemented years ago was one from a Navy SEAL, a nationwide program, Navy SEAL John Underwood, that taught at this stage of the game, once they were drug tested, taught the parents and the students about what substances can do to your physical performance and what it does to you on the playing field. It was very impactful, especially for those that are looking for scholarships and those are, looking for their sports to take them a long way. So it is being used as a prevention, early intervention. I would call it very early intervention in some of the schools. I know that the coalition in Carson City has funded it for many years, providing money to supplement what the school district can afford. And so we were looking at this as a recommendation for those school districts that felt comfortable. Did that help?
Yeah, thank you. I think something you said that was important to me was with their consent. So I really appreciate the clarification of the contracting process. Chair Dunyate, I do have a few more questions, but also want to yield my time. Would it be appropriate to ask them now or yield to the other committee members?
Let's go ahead and move on with Ms. Nadler, and if there are any other committee members, I'll go back. Ms. Nadler, please proceed.
Thank you.
Thank you. Thank you for the presentation, Jamie, Linda. That was awesome. I have a question, just a real quick question. And I love the secondary prevention and education, but I'm not seeing primary prevention. This has been, sorry, but my little battle, my little fight for the past 4 years. We are losing so many middle school kids who have absolutely no knowledge. I lost my cousin, 13 years old, in October. Wouldn't primary prevention be warnings to the kids before they even use? Because honestly, I have tried to get into the schools. I have a billboard out right now that I had to pay for myself. Well, Joe Engel helped. It's impossible to get into the schools to talk to them, or like you said, the teachers, they already have enough on their plates. We have no mental health counselors in the school. They've been cut back. So I'm not seeing primary prevention. Unless I'm totally missing something, I don't see primary prevention at all.
You're not, Debbie. And I have to tell you that these were recommendations that we put forward for things that are not currently happening in the state, because that are not funded at a very high level or at all. We were looking for new projects because there is resources through current grants to fund primary prevention. But I want to just focus you on one that is 100% primary prevention, and is the recommendation that Jamie Ross put forward about getting a certified prevention specialist in every school. I see that my good friend Dana Walburn is on this, and we have worked with Dana after the passage of SB 69 last legislative session. Most people know that as the peer support bill, but what was also included that is 3 legs of prevention. That was huge for us. 3 legs of prevention. One of them making it passive consent for the YRBS in the schools, huge to be able to get valid data. The second one was the coalition structure and putting that in a formalized process. But third, Debbie, was the start of evidence-based programming being consistent and constant in our schools. And we have worked with the Department of Education since that bill to get evidence-based programs onto a website so teachers have availability to look them up and embed them in their curriculum. What we believe very strongly is that the teachers do not need to become experts in the prevention field. They're experts in teaching and all the other millions of things that are asked of them. So what the ask is that we provide prevention specialists. That's what they're trained in across the state. And we provide them to be able to be made available to go into the schools and do this type of education that you're talking about. 100% primary prevention, Debbie.
Thank you. Yeah, we actually, Joe Engel and I put together a program, and we're going to present it next meeting. It's called Just Say No, KNOW, and it's through the art of communication, going into the schools, having them use communication to tell us what they know about drugs. So it's something we would like to present the next time. But thank you for clarifying that, because we're losing too many middle school kids now at this point.
Thank you so much, Ms. Nadler. Let's go ahead and keep moving on. Ms. Johnson, did you have any other clarifying questions or any other committee members? I don't see any, so Ms. Johnson, you can go ahead. Oh, actually, let's, if it's okay, let's let Senator Gansert go first.
Thanks, Senator Donate. So I appreciate all the information that's been provided today. And, Dr. Grigsby, when he was talking about the family-based trauma, when I talked to some folks locally here, they said, that's a huge piece of it. And so when you talked about expanding the pipeline, I think that's a large portion of this is how do we get more people on the ground to help people and ask the questions. And I also would agree that when you look at the school systems, the teachers have enough on their hands, right? So we have to figure out how we don't put it on their shoulders, but we create infrastructure that we can sustain to be able to help screen kids and provide information to kids that know KNOW, right? So they have better knowledge. And then we had the conversation about the drug testing. And I think there are groups of students who are athletes or who are interested in academics and want to go to certain places where they don't want to be precluded or prohibited from certain activities or things that would be defined as success for them, whether it be athletics or academics or whatever. And knowing that potential drug testing is out there may help keep them on the straight and narrow if they don't want to be excluded. So those are kind of the only comments that I have, but I have heard a lot about the family-based trauma and so much some of the choices that young people make are associated with a disconnection that they may have had with their families because of certain incidents. And that was, it makes total sense, but, I think there's a developing framework around that and how to help individuals at an early age, if they can identify that. So thank you.
Thank you for those comments and the support. And I agree, the ACEs is the model, and it is something that people are becoming very, very educated about, but really embedding it in a very early age and looking at these, key adverse childhood experiences. It's something that we need to focus on much, much more. We talk about risk and protective factors. This is the ultimate model to identify those factors. So thank you for your comments.
Great, thank you so much. Ms. Johnson, please proceed.
Yeah, thank you. Thank you, Chair Daniate. Just a couple more questions. I really appreciated this presentation, and I wanted to ask a little bit more about the current funding around primary prevention, if that would be all right. I know this really focused on secondary prevention, but I guess I would be curious from the coalition perspective, do you feel like the level of funding to scale up primary prevention is sort of what's needed at this point, or are there challenges with scale up? I'm thinking in particular like the difference between Clark County and my colleagues in Mineral County or Douglas County, and I was wondering if you could just share, or are all of those places ready and we're just focusing more with some of those secondary prevention efforts?
I can answer this one, Linda, if that's okay. I apologize for not having my camera on. My Wi-Fi is not as awesome as it should be. Yes, so I think that is definitely an issue. There is currently funding for primary prevention through, most of that funding actually goes through SAPTA, which is the Substance Abuse Prevention and Treatment Agency, although they're now called the Bureau, formerly known as SAPTA, I think. And really what we have seen is that there is amazing work happening with that funding, but there is not nearly enough. And so we're hoping, and that's one of the reasons that we talked about adding certified prevention specialists to every school, is we know that scalability within our school programs, especially with the 241 elementary schools that we have in Clark, is a really big challenge. But also understanding that each community has their own needs, and buying computers for a community that doesn't have Wi-Fi is not useful. So making sure that this information goes all the way down to the community and the coalition level. So yes, I think to answer your question, Linda, you have more detailed information than I do probably.
I have to add one other thing in there is, Jamie is correct, except that a lot of the funds are 5-year funding sources. As you know, Jess, they're 3-year funding sources. It's not constant. The only dollars are our state, infrastructure funds that we have. And as I said, those have decreased since 2007 quite dramatically. And so one of the things is that we're losing another grant next year. It's close to $2 million that we're using that funds all of our alcohol, methamphetamine, marijuana. Well, not all of it. That's the major focus of the grant. I apologize. We're losing that in 2023. And and our state did not, unfortunately, they did not have the capacity to apply for the next source of funding for that. That was PFS. I have that listed in one of the funding columns, is to replace those dollars. The next grant came out for the PFS and it was not applied for by our state. So no, we are not set for primary prevention at all.
Ms. Johnson, did you have any further questions or? No?
No, thank you, Chair.
Okay, Ms. Nadler, I saw you have one more question, and then I think after this we can proceed to the next agenda item. Ms. Adler?
Sorry. In secondary prevention, would that be items such as maybe perhaps mandating warning labels on marijuana? I mean, when we're talking about secondary prevention and drug testing, would that would include marijuana? I mean, it is legal in our state, so.
Yeah,
No.
so Ms. Nadler, just to let you know, there already are requirements for
Right.
cannabis sales to include that sort of,
Warning.
that's, yeah, warnings or notifications. That's heavily regulated itself. So if there are things that you would recommend to change or to modify, I think that would be part of the recommendations that we would include if you wanted to.
Yeah, I do. Okay, thank you. I just wondered that. Thank you.
Of course. Any other questions or at this time? No? Okay, Ms. Lane, thank you again. We really appreciate your participation, of course, to Jamie as well. So we're very thankful, and then we look forward again, like I mentioned to Dr. Grigsby earlier, as we're thinking in for our policy proposal before we create a full recommendation, we would love for your feedback and recommendation or review, of course. So thank you again. Let's go ahead and move on to our next agenda item, which is to review subcommittee recommendations. So I want to go ahead and spend these next few moments reviewing having a conversation between just the committee members as to what our expectations are with some of the recommendations that we're starting to get. So of course, as we're talking about this, I just want to make sure that for all the committee members that it is not expected that the subcommittees will bring recommendations forward in the full SURG meeting on June 7th. Rather, we're going to be sharing our process to date and the presentations that we have been asked to receive or planned, and of course, to describe how we're going to prioritize the different proposals that we're getting. Of course, if you have any questions or if you have any recommendations yourself, we can have that as part of our June meeting review, but I just wanted to make sure that we knew well in advance that our full recommendations are not going to be done by the time we have our June meeting. And then also just for clarification purposes, Emma will go ahead and share the slides with recommendations that we received at some point. But for today, I think it'd be great if we can just talk about some of the recommendations that we've heard from our own community groups, and then talk about the expectations for prioritization. So I want to go ahead and just speak freely, really quick about how we can navigate the recommendations. So I have been asked myself to have, so I've been getting a lot of meeting requests individually as to what folks in the community feel should be prioritized in this space, as I'm sure many of you have been getting as well from your own colleagues in the public health space or in the community. And so what I envision, of course, I mean, we could have a survey, we could review these recommendations, and it probably might be useful for us to do it on an individual one-on-one basis too, as we come through some of the proposals. But what won't happen, based on my conversations with the committee staff, what's not going to happen is we're not going to have essentially like 5 different proposals from each of the different committee members. I don't think that's good policy in its sense. But what might happen would be, for instance, we as a committee, we determine that we want to focus on 2 policy proposals, and in those policy proposals, we will have primary, secondary, and tertiary prevention ingrained into each of them. Or we might decide that there are 10 different things that we want to focus on, and those 10 different things might have primary, secondary, tertiary prevention listed in some of them. I think that might be what will end up happening as we start to decide, okay, this is what we're going to prioritize. Maybe this is not what we want to prioritize, simply because, as you know, a lot of it comes down to infrastructure and what we can push forward. Some of it might be dollars that we choose to spend in prevention right now to provide relief, and some of it might be in infrastructure wise so that we can continue to apply for grants at a later time. But I would like to hear from, at this time, from any of the committee members as to if there are proposals that you think should be prioritized, and perhaps Emma, if you want to have any, I'll give you the chance to talk as well with some of the recommendations we've received. Emma, you want to go ahead and proceed?
Sure. So I think, so we had the deadline ahead of this meeting and to submit recommendations, so that way we could get it posted on the SURG website, and it was accessible to the public. The only recommendations we received ahead of the deadline was from Eric on behalf of the prevention coalitions, which Linda and Jamie presented on today. There are also recommendations you'll see in the tracker. And if you go to the SURG website, you'll be able to pull that up quickly. That came from the IHC. So any recommendations that came in those earlier presentations, again, they weren't to this committee, but just to save everybody's time, we did send the members those links so you could view those presentations. So we pulled out recommendations from the IHC and put those in there. So what you're able to access now is everything that was submitted ahead of the deadline. And I believe the process is ahead of each subcommittee meeting. So we'll have another one in June, and I believe another one in August. All of the members will again be able to submit their recommendations, and then eventually you all will need to decide your process for prioritizing those recommendations.
Great, thank you so much, Emma.
Just to clarify, sorry, Chair Dinyate, Emma, the subcommittees would be meeting July and August. It's the full SURG that's going to meet in June. Just
yes,
just to clarify. Thank you.
Great, thank you so much, Emma. Committee members, at this time, I'd like to hear if there's any recommendations on how you would like to see us prioritize policies or recommendations that we get forward. If there's any best practices that you would like from this process. Again, I do anticipate having individual meetings with one of you, with each of you, just to go through some of the things that to learn as to what you feel we should prioritize, and as we start to collate a lot of these. So Ms. Nadler, you can go ahead. Ms. Nadler?
I'm sorry. I can't tell if I have it mute or unmute. I submitted a proposal to Emma, and I did it too late. I'm so sorry. I'm in the middle of a move, but I strongly believe, and I've just seen it too much, I see what's going on, that primary prevention programs absolutely needs to be on top of the game. I agree with the secondary too, but I think we've got to do something with primary and social and emotional learning in the classrooms in early childhood education. Our kids have gone through too much trauma with COVID and everything else. So that's my thoughts. And I have a program that we put together, and I'd like to present it at some point. I turned it in too late.
Gotcha. Thank you so much for that feedback. Any other committee members on how we can prioritize the recommendations that we get, or if there's any review processes that we can implement at this time to help us go through and collate these different policy proposals? Ms. Johnson, looks like you unmuted yourself. Go for it.
Yeah, sorry. I will defer to yours and Senator Ganser's expertise in terms of policy prioritization. I was wondering if there maybe we could discuss some like key indicators, and then one idea might be to sort of rank these across, potential impact to save lives, like cost effectiveness. Maybe there are a few sort of shared areas. I know the tracker does a great job of sort of identifying the priority populations and the existing funding and those types of things. But the way that I've seen some of this work done before is through the identification of some of those either common indicators that we agree either with consensus or vote on as a committee in a ranking fashion. And maybe that's a way or to approach this. Just one thought, I don't have a particular framework in mind. I'd be happy to research and connect back with the SEI team about that. I don't know if that's a structure that you've used in the past. But might be a way to, there's a lot of really excellent items on this sheet. And so, you know, or if there's recommendations for to synergize some of them or to break some of them apart if they're multifaceted. So those are kind of my initial thoughts on prioritization.
Great, thank you so much. Any other committee members or any other comments or thoughts regarding prioritization? I think a lot of it will come out as we're receiving these recommendations and we start to decide, oh, okay, together as a committee, we can move forward with this proposal, or here's what we see from this proposal, or what's missing based on the presentations that we've gotten. I think that a lot of that will come in fruition soon rather than later. But I just wanted to make sure that we had the chance to discuss if there are any things that we wanted to choose to prioritize during this time. Okay. Great. I don't see any other comments, so I will go ahead and move on to our next agenda item, which is the discussion of future meetings and topics and presentations. So I know this is probably, we've talked about it today. And so given the differences of proposals that we're getting and recommendations, I wanted to get the chance to outline for you some of my expectations as to what the follow-up meetings will be beyond this moment. So of course, today we had our May prevention meeting, which was to talk about what does prevention look like in this space and how can we understand the different risk factors that are coming from substance misuse. Our follow-up meeting in July, my goal for that meeting would be to focus. So the following meetings would be subjugated into 3 different categories. We've talked about primary, secondary, and tertiary prevention. So our following meeting will be to discuss primary prevention and focus. So perhaps if we wanted to, we can talk about health education reform, which is something that Dr. Grigsby talked about to improve health literacy. We can also talk about grant dollars. I think that was a conversation that we had today. So I'd like to do a deeper dive as to what are the grant dollars that we're missing out on simply because of infrastructure, and how can we ensure that we're getting that information, or where do we need to invest to get more funding out of it. And then we have a few presentation proposals to discuss YRBSS and BRFSS as part of the data collection mechanisms, and as we discussed earlier. The August meeting, right now, we're looking to talk about secondary prevention. We touched on a little bit of that today. So we'll talk about screening and the integration of behavioral health. And of course, we have potential presentations on payment management during this space. And then the third meeting would be to focus on tertiary prevention and harm reduction. So we have folks from the Southern Nevada Health District that could speak to us, the law enforcement partners, and then different folks that are involved, whether with naloxone distribution or any of the things that we've already talked about within the last few years for harm reduction. So that's the template so far right now for presenting the different and spacing it out. That way we can be focused on each separate subject in one manner, and it doesn't deter or take over the conversation of another space. I think prevention in itself is complex, and it requires for us to think about it holistically, not just in terms of one aspect or the other, because they're all important. And so I think that by following this meeting structure, I would hope that we would accomplish that. Are there any recommendations or anything, given the outline that I've given, of things that we could include or improve on. I think Senator Severs-Gansford, did you want to say something? No, you're good. Okay, Ms. Johnson.
Yeah, thank you, Chair Dunyate. So I just wanted to mention, I think in your list, as I was categorizing them, I heard harm reduction towards the end of the calendar year, if that was correct. As someone who works in that space in my daytime job, there have been quite a few advancements in policy across other states in that area. So I'm curious, there may be some recommendations that perhaps come out of that meeting based on what some other states did during this legislative session that they had this particular year. So I don't know if it would be advantageous to move that up from the end of the year slightly sooner, just wanting the opportunity to digest those ahead of the 2023 session. But all the rest of the schedule, I mean, it sounds like you have a great pulse on the purview of the committee and touching on all of those areas.
Sure, and I'll go ahead and discuss with the committee staff as to moving around based on priority. My goal is still to have 3 separate meetings focused on the different tiers of prevention. And then hopefully that we accomplish a lot of it. I don't really have a priority in terms of which one goes first. But if the opportunity is there, based on timelines, of course, of national conversations and what's happening, especially given the deadline for BDR introductions for legislators, if that's something that we want to consider, I would be more than welcome to do that. So I'll go ahead and follow up with the committee stuff on that. So thank you for bringing that up. Any other comments or any other suggestions? I don't think, Emma, did you want to say something?
I would just say that if any of the subcommittee members have a recommendation for a presenter, to please email Chair Doñate and myself. You know, we want to be mindful to get people's presentations in while keeping these meetings, you know, to a good amount of time so they're accessible.
Right, and then I would also express, Ms. Johnson, you mentioned that if there's policy proposals that are happening in other states, feel free to send that over. If there are experts or legislators in other states that are introducing them, send them to us, and then that'd be helpful too. A lot of times good policy proposals don't require money, just throwing that out there. There's just a lot of work that goes behind them. But of course, funding does go a lot into public health. So great. I don't see any other recommendations or anything else. So let's go ahead and close this agenda item, which brings us to the conclusion of our meeting. Before we conclude, we have one more public comment. So I'll open this opportunity for any of the members of the public that would like to go ahead and, given today's meeting, give their public comment. So Miss Emma, is there anyone on the line that would like to provide public comment at this time?
I do not see anybody either joining by phone or computer who has their hand raised. So I think we're good.
Sounds good. Thank you so much.
Madeline Larson had her hand briefly raised. Sorry.
I never had my hand raised, but I'll definitely introduce myself. I'm Madeline Larson, a Master's of Public Health student, and I loved all of the presentations today. I'm going to try to get in contact with some people, see if I could do any like volunteering or anything, but it's super interesting to see all this stuff. So thank you.
Thank you so much for your public comment. Is there anyone else that would like to provide public comment at this time? Seeing none, I'll go ahead and close public comment. Thank you again to our committee members and our presenters for today's meeting. I'm excited to see where we end up within the next few months, of course, as we continue to get more policy proposals submitted. So I'll go ahead and adjourn this meeting. So thank you so much and have a great rest of your day.
Thank you.
Thank you.